And I promise not to talk straight through the whole break. So you'll notice I think I have 100+ slides in the talk that I submitted. I think we'll have far less than half of that. And I'm going to focus on some of the issues related to radiotherapy, but also general prognostic factors and chemoradiation. So vulvar cancer has increased slightly as HPV, again, has become more recognized, and of course population growth, but we're still only at 6,000 cases per year, so it's a relatively rare cancer overall. Rarer than most of the other GYN malignancies. It's less than 5% of all female genital cancers, less than 1 to 2% of cancer in women. The death to incidence ratio was about 3,600 to 800. And it's, as you know, mainly observed in the 7th to 8th decades, although with HPV increasing, it's again in earlier age patients. The natural history, of course, local vulvar primarily then spreads either through skin or through lymphatic to adjacent tissues, inguinal, femoral, and then the deep inguinal nodes and to the pelvic. Pelvic nodes are positive in a minority of patients unless the inguinal nodes are involved. And the primary failure pattern is local regional with metastases of the lungs occurring generally after there's been either local regional failure or neglected, unresected disease. The staging system, I'll list here, and we'll just skip through that. You already heard through pathology that there are these distinct pathways, HPV dependent and independent, and these have very distinct pathologic and molecular features. Now, with regards to HPV and radiation, to some extent the jury's still out because this is an understudied disease. We certainly know as a general principle that HPV-related malignancies are much more sensitive, and I think we've gone through the classification. And then we published the relapse rates by HPV status in terms of those that had radiation and found that patients that were HPV negative had a much higher in-field relapse rate. And so you can see that the 3-year in-field relapse rate in a series of patients from the Brigham and Dana-Farber was 32% in HPV positive versus 64% in non-HPV related cancers. And there was obviously the same ratio for vulvar recurrence and nodal recurrence. And all were highly significant. So we looked at HPV staining and found that P16 was a simple correlate. Of course, you don't get subtype, but it is easily available and I think much more universally able to run a P16 stain. And so we ran this and correlated HPV to P16 in terms of survival and also relapse rates. And so you can see here how overall survival was again correlated directly to HPV-16 and P16 status. What we showed on multivariate analysis was that the intent of giving radiation was highly predictive and that the rates of in-field recurrence were significantly lower in HPV positive. So the hazard ratio was 0.2 if you had HPV for in-field recurrence, 0.4 for progression-free survival, and 0.6 for overall survival. And again, the in-field recurrence from a radiation oncologist perspective is the issue. Can we dose escalate or do we need to do post-radiation surgery in patients that are requiring radiotherapy because they are HPV negative? So remember, you're referring patients to us either in the postoperative setting, and in those cases, they would not need adjuvant surgery. But in the locally advanced population, is there a subset of patients that because they are HPV negative, once the tumor is regressed, would they do better because they have a high rate of in-field recurrence subsequently? These are unstudied and unknown, but I'm just, questions for the future. Really, should we be considering more extensive surgery in the patients that are HPV negative, even if they have shrinkage or an apparent response to radiotherapy? So they're really, radiation in this area is quite complex. We think about, how do you treat the primary, how do you treat the nodes, and we all wish we had a crystal ball to see where the patients are going to relapse. We, of course, don't, but we know that we have some prognostic factors, including depth of invasion, tumor size, LVI. The primary one for the vulva is margin status, and then histology. For nodes, it's a little bit easier. If the nodes are positive, we radiate. But even if the nodes are negative, sometimes we worry about risk. So, for example, contralateral nodes being positive, do we radiate the other side? If there are extensive nodes on one side, do you radiate the pelvic nodes? If only the inguinal nodes are involved. And then do we need to change the dose of radiation based on the extent of disease? So the number of nodes, whether there's extracapsular extension, if the nodes resected were larger, if there's any signs of residual disease. So these are all things that we grapple with. Now, I think you all know that margins, whether or not there's gross residual, close margins or fully resected tumor is imperative for us to understand. So we really push our pathologists, if that's not automatically given. In centers where there's a GYN pathologist, it's pretty clear you're going to get your margin status, but there are times when a general gynecologist has resected the tumor and we need to resend the pathology to make sure we get a very clear read of whether there's invasive cancer or pre-invasive, the VIN, et cetera, or HSIL, at the edge of the specimen, and to determine that. Now, there's several studies that have over time looked at predictors for local recurrence and factors that impact vulvar recurrence besides margins. So this was one study published now a few decades ago that looked at simple vulvectomy followed by radiation at a very low dose. And they're followed with a GOG clinical pathologic study that looked at whether or not tumor size and LVI were predictive. And they did, in fact, show that these non-margin related factors could predict recurrence. But in these series, the depth of stromal invasion did not. The depth of stromal invasion overall has been quantified in millimeters and increases the risk primarily not of vulvar recurrence, but of lymph node involvement. So we're really using it as an overall risk predictor for whether or not we think there might be micrometastatic disease in the lymph nodes. Tumor size, similarly, is not as much a predictor of local recurrence in the data as it is a predictor of lymph node metastases. So, it stands to reason, larger tumors, higher risk. You can see here the ratios, but we're not necessarily treating the vulva if the lymph nodes are negative unless we're dealing with multiple factors, including a large fully resected tumor that also has high grade and LVI. And then it's quite controversial. There are people in the US right now creating a multi-institutional series to try to look at the SEDLIS criteria type factors because we don't know how to score each one of these separate factors to predict who needs radiotherapy in the patients that, besides margins that have large tumor size, LVI, and high grade, for example. So that is an unknown entity in vulvar cancer. But, I do think it's important to realize that the reason why this hasn't been done, not only is it rare, but that the most important prognostic factor is lymph node status. So knowing that all these things predict lymph nodes, it's lymph node status that really predicts survival. We have a golden rule for in the U.S. for the residents that if the patient with vulvar cancer fails in the groin, they die of disease. And so your primary goal is always to ensure that you take care of the groin because there is no patient who has failed in the groin that's really had a long-term survival rate. It's just essentially an incurable entity based on the literature. Now, there may be occasional cases here and there, but it is certainly not universally accepted. So what can we do? Radiotherapy. We give generally radiotherapy for, when the surgery was pretty close but not quite clear. So there is data that most commonly cited is the first paper published, the HEAPS paper, where there were 135 patients, 37 of which had close margins. The years in the HEAPS paper for the patients were 1957 to 1985. So, we all talk about HEAPS, but it's really this, large series of 30 years of accumulated data. And none of those patients received radiation, and the local recurrence rate was 16%. There has subsequently been a study in the University of Pittsburgh that had 34 patients that have close margins, again, accrued from 1980 to 2004. Again, retrospective reviews, of course. 50% of those patients had radiation, and their relapse rate was 16% in those that had radiation. There was a study from John Chan, who was at UC Irvine at that point, 53 patients with close margins, reviewed 1984 to 2000. 20% of them had radiation, and there was a 16% overall local recurrence rate, 25% in those that had close margins. And in the Brigham Farber, we looked at our data. We had 205 total patients. 116 of those, they were all centrally re-reviewed by Chris Crum, so he went back and scored every single slide. And we looked at 1980 to 2009. 30% of those patients had radiation, and there was a 30% local recurrence rate. There are other studies. There's an NCDB data looking at positive margins. Because they didn't have central path review, I'm not including those because I really wanted to focus on the concept of close margins today. But as I mentioned from the UCLA, the HEAPS data, there were 21 local recurrences, and they found on their multivariate that the increasing tumor-free distance was associated with decreased local recurrence. This is kind of common sense. It's not that 8 millimeters is a magic number. It's a continuous variable whereby each millimeter there's increased risk. So why do we all teach 8 millimeters? Because it's simple, and at that point you're relatively safe in saying that you've kind of overcome the greatest risk of local recurrence. And it's, we're all trying to work in algorithms that work, but you have to really take into account when you see a patient, if they have 5 millimeter margins, but they also have a very high risk profile in terms of large tumor size and other factors in the vulva that you'd radiate. But if they had 9 millimeter margins in those factors, you wouldn't. I mean, I think you have to think about, is it a young patient? Is it a sensitive disease? And again, we're going based on very limited retrospective series here. So individualizing care, I think, is always very important, as well as going by known data. So in the HEAPS data, there were only 7 patients that had positive margins, and 4 of them relapsed. In the HEAPS data, 44 patients had margins less than 8 millimeters, of which 21 of them had a local relapse. Remember, none of these patients received radiation. And the highest overall predictive accuracy of reaching 87%, non-relapse was the margin distance of 4.8 millimeters. So they found there were significant on univariate analysis. They didn't do the multivariate. Was other predictors were depth of invasion, LVI, and infiltrating growth pattern. So those are the things to kind of consider in the analysis that you might do. So the University of Pittsburgh study, I mentioned already, 34 had close margins. And these are their prognostic factors. They, in contrast to the HEAP study, had radiation and showed that radiation was highly significant for both local control and overall survival. Local control was on multivariate analysis. So again, the difference from the HEAP study with this University of Pittsburgh study was that they had patients that received radiation and showed that giving radiation to patients with close margins improved local control on a multivariate analysis, and that resulted in improved overall survival and univariate analysis. Yes. All right. The Chan study, again, 90 patients, 53 of them had close margins, and 12 of those recurred. and they did do a multivariate analysis for progression-free survival, and again, looked at margins as a continuous variable and showed that decreasing pathologic margin and greater than 2 positive groin nodes was significant, but they did not see an association with stage, histology, grade, depth of invasion, tumor thickness, or tumor size. And this is just a summary of that. The Brigham-Farber data showed that there was a 34% overall risk of local recurrence, and in the subgroup of patients, the 116 that had close margins, 40 had radiation, and the vulvar recurrence appeared to improve with dose greater than 56 gray, but there were too few patients in the two subgroups to really quantify it much more broadly than just dichotomizing it. So there probably is a benefit with some higher dose, but we didn't have enough patients in those groups. So this is where really accumulating multi-institutional data will help to tease out what are the patients with close margins and the doses of radiation that they receive, what dose do they need in order to adequately control the disease. As I showed, even with those over 56 gray, there was a 21% risk of recurrence, so it's still high. These are just on univariate analysis, the prognostic factors from the Brigham-Farber data, and this was just the distance to the closest margin. So in 55 patients that had, and that should be 0.5 centimeter to 1.5 centimeters, 7 had a vulvar recurrence. And the freedom from vulvar relapse, if it was greater than 5 millimeters, then there was a significant reduction in risk. So if trying to dichotomize it in this data, 5 millimeters ended up being the significant number instead of 8. But again, that's grouping data, and I really think it's important to realize it's just a progression, and once you hit 8 or 1 centimeter, you're really getting to a drop off in terms of risk, but that 5 millimeters is really what is a bare minimum to strive for in terms of thinking about need for further surgery or repeating surgical resection. The dose of radiation, as I mentioned, there are really too few cases to make a big deal out of this. We tried to dichotomize it by this 56 gray, but again, I think it's preliminary, and we certainly need to repeat it with more cases. So this is just a summary of all of those margin status papers that are out there. Really a hodgepodge of data, I think, as you can probably get from what I'm saying. It's hard to know, but that we can conclude that margin status is related to vulvar recurrence. We've traditionally used 8 millimeters. Some of these series talk about 5 millimeters, and others say that their conclusion, even though they don't really show the data that much, but is that 1 centimeter would be adequate. Use of radiation and at what margin state is not known. HEAPS did not have radiation. So we always say if they have margins less than 8 millimeters, you should radiate. But that was not what was analyzed in HEAPS. HEAPS just said if they have less than 8 millimeter margins, they have an increased risk. The other studies looked at radiation and found slightly different cutoffs. So this is, again, a question for the future. Should we be radiating for 5 millimeter margins or for 1 centimeter margins? The data is not clear. But there's obviously a careful balance between the risk of recurrence and the ability to salvage in the future, right? So because of the topic of salvage, how many patients that relapse in the vulva can you actually salvage? I'm going to turn to Groins V1. So this is, where we rely very much on our European colleagues to help because of the nationalized systems that we have many, many more cases. And in the Groins V1 study, they had 377 patients, published 10-year follow-up data, and for patients that had, this is of course a sentinel node study, but they do actually report on vulvar recurrences. It's not about margin status, but I think tracking out what happens when somebody fails in the vulva is important. So patients were T1, had less than 4 centimeter primary tumors, and they categorized them as local, which meant vulva or the vulvar tissue, groin, and distant recurrence. So that's how they reported their recurrences. And if you look, they had, out of 377 patients, 119 had local, meaning vulvar region recurrence. Of those 119 that failed in the vulva and went through surgery again, 58 of them had a second local recurrence, 3 had groin recurrence, 1 had distant. Of those that had a second local recurrence and then re-resected again, 18 had a local recurrence, 5 then turned into distant. And again, if they went through surgery a third time to the vulva, again, this could be another site in the vulva, right? 6 had a local recurrence, 1 unknown. Why do I take you through that? Because these patients are going through recurrence after recurrence in the vulva. They're getting resection after resection, and they're failing more in the groin and distantly with each time, meaning the biology is getting slightly worse. It's not remaining just local. It's starting to spread. Either it's, presumably are patients who are undergoing close follow-up, that they're seeing a surgeon regularly because they've had re-resection, and that it's not that they're being missed and have undiagnosed recurrence between surgeries. Why does that matter? Because here in Groins v1, they published their local recurrence data. Local recurrence, again, vulvar recurrence, and they showed that patients that had a vulvar recurrence had a lower survival than those that did not. That's, you would think that, but nobody had shown that until this point with a large series of data. So what does that mean? Again, these patients generally did not get radiated for their vulvar recurrence. They waited and they did repeat surgery. And that's been the historic trend, is to just say, we don't need to radiate if you have a local recurrence. This, because of the survival difference, 10-year disease-specific survival decreased from 90% for patients without to 69% for patients with a local recurrence that was highly significant. What does that mean? That means that we've always said if they fail in the groin, they die. This data says that if they fail in the vulva, they die too. It's not as bad as the groin. It's 69 versus 90%, but I think it's an underappreciated part of vulvar cancer that we are not adequately addressing vulvar recurrences. We're not comprehensively addressing vulvar recurrences. That what we should be thinking of is at the time of first recurrence in the vulva, should we be implementing more extensive treatment? Should we be giving chemoradiation to those patients to prevent that next recurrence, which might turn into groin and or distant recurrences? And that's where I think we need to go with our understanding. Or is there some other therapy or more extensive surgery, right? So we're starting with smaller surgeries. Are we now seeing more recurrences as a result? Unknown. Food for thought. I'm going to just flip, because I just have a few minutes, to locally advanced vulvar cancer, and just say that in this entity, we are defining locally advanced as unresectable because there's invasion into the anus, the clitoris, the urethra, the vagina, or bone, or any other normal tissue, muscle, et cetera, that's unresectable. And the treatment that we've given has generally been definitive chemoradiation. Now, given that a lot of these women are in their 70s and 80s, the question becomes, what does that mean? There are studies that have looked at 5-FU and mitomycin with radiation. Of course, that's highly toxic in terms of diarrhea risk and bone marrow suppression. So other studies have looked at definitive radiation with weekly cisplatin. I did a retrospective comparison of platinum versus 5-FU and platinum. And there are studies that have looked at 5-FU platinum with radiation to 40 to 50 gray. And what we can say is that, especially in elder women, it's important to tailor, I think, the chemo if given. So instead of cisplatin, we sometimes use carboplatin with an AUC of 1, like we would with elderly patients in cervical cancer, but that we don't have much data. Again, these are studies of 9 patients, 12 patients, 16 patients, and then a SEER and NCDB analysis. But again, chemoradiation is what we do. In terms of contouring for radiation oncologists, we developed a contouring guideline that was published in 2016. Just so everybody knows, this is now software that's on the NRG website where you can go in and find the contouring tools and look at how to treat. So we historically used to treat front to back APPA and very wide fields when our machines and our technology were not very refined, and we would cover that extensive area of the pelvis, the inguinal nodes, the entire vulva. And while that was very toxic and created a lot of skin breakdown and, patients required hospitalization to get through this, we, of course, continued to cover all of the areas of disease. So we've switched then in the 90s to the forefield, where we eliminated some of the anal region, some of the bowel anteriorly, and now more recently to IMRT, where we have much more refined contours and create these, fine regions where we're either treating the entire vulva or we could treat just a tiny small part of the vulva. You have to be very, very careful, though, in this area about under-treating. Again, there's very little data to guide us as to what are the right structures, because we always treated everything. So if you think about patterns of spread, the biggest areas of controversy are, do you treat the skin bridge between the groin and the vulva? Right, you surgically wouldn't resect it, so we now with IMRT are not treating it with radiation. But historically, we always did, and we were, of course, treating patients with positive nodes. So is that an area where we're going to start seeing more failures? We don't know. The other thing we've learned is that in the groins trial was that they were contouring just the vessels, and as a result of contouring just the vessels, which are not where the nodes are, they had a high groin relapse rate. And so they changed it for the update. So you'll notice that in Groins V2 in the update, they modified their radiotherapy treatment plans to cover the pocket, which is what's actually standardly recommended. But I think the trial had been written before those recommendations were released. And so we contour actually the bed around the vessels. But what we found is that you also can spare, sorry that the words seem to slip over, but you can spare the region that is going towards the femoral head in the muscle, because we don't really get recurrences that the lymphatics are pretty much at the vessel or above. And so those are the areas that we need to treat. You do, for patients that require pelvic node treatment, need to connect the femoral to the pelvic nodes, and that we are basically treating just up to the level of the skin, but don't necessarily need to include the skin unless there was true skin invasion or there's locally advanced disease. We contour all the way down to the saphenous vessel and cover it, and for urethral, clitoral, or vaginal lesions, we contour basically up to the level of the bladder neck, or in the vagina, we contour at least 3 centimeters of the lower vagina. So it's not that we treat just the tumor plus a margin, we treat at least 3 centimeters of the normal tissue structure. We do replan if there's swelling. You can get quite a bit of edema in the vulva during treatment and may need to actually replan. The other thing you have to be very careful of for the radiation oncologists in the field is that you don't do just tangential fields and then the swelling will push the tumor away. You have to ensure that there is an en face field so that it goes through the vulva as the vulva swells. And then these are just the doses. So basically for nodal regions that are uninvolved, 45 gray, resected nodes 50, and then we boost again with IMRT up to 65 to 70 gray for gross disease. I'll just say we have to always be aware that this is a disease where there are quite significant toxicities, both in the short term and the late term, and therefore follow-up is critical. And as radiation oncologists, given the severity of some of these side effects, we do see our patients quite frequently in the short term. At 3 months, we make sure that the skin is fully healed. So after patients finish, we see patients between 2 and 4 weeks post-treatment to ensure that there's no skin infection in the acute phase as the skin heals, and then in the longer term, make sure that there's no proctitis if they had dose escalation from a tumor that was adjacent to the anus or rectum. And with that, I will finish and say thank you.